Hey everyone, this is Megan and I'm here with Anna and we're the fourth year students with Dr. McClendon at Glen Eyre this month. Our presentation is going to focus on mycoplasmic pneumonia treatment. And we'll see objectives. The first one is to define mycoplasmic pneumonia and the related signs and symptoms. Then we're going to discuss the microbiology and epidemiology of Mycoplasma pneumoniae infections. And then we're going to identify the options for treatment and prevention of mycoplasmic pneumonia.
So Mycoplasma pneumonia, it's an atypical bacterium. It causes infection by damaging the lining in the respiratory system. So that includes the throat, lungs, and windpipe. There are a multitude of nonspecific symptoms, and those are listed on the slide, such as tracheobronchitis, pharyngitis, malaise, fever, cough, and headache. Those are the ones that infection commonly results in. Infections are typically self-resolving, and they're often likely to be undetected. So due to the relatively mild nature of many of the infections, the presentation is often very similar to things like pneumonia. So many infections as well as clusters and outbreaks are likely to be undetected. Common complications include pneumonia, often known as walking pneumonia, asthma exacerbations, encephalitis, and hemolytic anemia.
So moving on to the epidemiology, the United States doesn't typically record the cases of mycoplasmic pneumonia, but it's estimated to cause about 2 million cases per year, and then it makes up about 10 to 40% of all the community-acquired pneumonia cases. And so most infections actually occur in school-age children and young adults, but those with underlying lung conditions like asthma or COPD are at a higher risk of this infection. And then places that people live in close quarters, like nursing homes and college dorms, are places that outbreaks generally occur. And then seasonally, they usually occur during late summer or early fall.
So moving into the microbiology and pathogenesis, the bacterium does lack a cell wall, which allows it to alter its shape and size to fit into surrounding conditions. That also makes it resistant to common antimicrobials that we typically use that target the cell wall, such as penicillins and cephalosporins. It's also not visible by gram staining due to this. So the specialized attachment organelle that the bacterium has allows it to closely associate to host cells, and that prevents the host clearance mechanisms from removing the bacterium from the body. That also aids in infection and survival for the Mycoplasma bacterium. So it attaches to and damages the respiratory epithelial cells, and that therefore activates the innate immune body and causes cytolytic effects. Transmission is typically person to person from airborne droplets, so by cough or sneeze. Most people who spend a short amount of time together don't typically get the infection. It often spreads between people who live in close proximity and often spend a lot of time together. And the incubation period ranges between 1 to 4 weeks, and shorter and longer durations are possible.
The clinical presentation of this infection is relatively nonspecific, and it's similar to the symptoms and signs seen with most respiratory infections, like a productive cough, fever and chills, shortness of breath, chest pain, and fatigue. Symptoms generally occur gradually, and they can persist for weeks to even months. And lab detection of infection for diagnosis usually includes molecular-based methods like PCR, also can include serology or cultures, but this usually isn't done in practice as treatment would not change based on the microbiology results. And the diagnosis of community-acquired pneumonia in general typically involves a chest x-ray that shows infiltrates upon exam.
So looking at the treatment, it is the same as the standard of care for community-acquired pneumonia. So that's when we empirically cover our most likely pathogens with antibiotics. Though most of the infections are self-limiting and resolve on their own, when pneumonia is a complication, treatment is usually given. So the chart on the slide is the initial treatment strategies for outpatients with community-acquired pneumonia. So these are the standard regimens broken down patient specifically by if they have comorbidities or if they don't. So if a patient does not have any comorbidities or risk factors for MRSA or Pseudomonas, we typically see high-dose amoxicillin or doxycycline or a macrolide. If a patient has comorbidities, that's when combination therapy comes into the picture, and we're moving up to augmentin or cephalosporin, in addition to a macrolide or doxycycline or monotherapy with a respiratory fluoroquinolone. So the duration of therapy, it's based on the appropriate response to treatment. So it's going to be guided by clinical presentation. We typically see a minimum of 5 days total, in addition to clinical improvement and resolution of abnormalities. So heart rate, respiratory rate, blood pressure, O2 stats, and temperature have to have reason. If MRSA or Pseudomonas is present, duration will be extended for those cases. And then repeat chest imaging is not necessary in patients whose symptoms improve within 5 to 7 days.
In terms of prevention, there's no specific vaccine to prevent this type of pneumonia, and we don't routinely have antibiotic prophylaxis for people, but there's some evidence for the use of azithromycin in prevention during outbreaks in places of close living conditions like nursing homes, although it's not routinely done in practice. So our best prevention techniques include the same for most infectious diseases, and they are personal hygiene, like proper and often hand washing, covering your mouth and nose when coughing or sneezing, or wearing a mask when necessary, and then also staying away from people who are sick will help prevent getting this infection. So in summary, Mycoplasma pneumoniae is an atypical bacteria that causes a variety of infections, including pneumonia. It's most common in school-aged children, but the risk is increased with people who live in crowded conditions like nursing homes and college dorms. Signs and symptoms are relatively nonspecific, and they include fever, cough, fatigue, and shortness of breath. And then most cases are self-limiting, but like we mentioned, they're often treated with antibiotics. And the prevention strategies include covering your cough and sneeze, and then avoiding close contact with those that are sick. And so we included some additional resources for you to learn a little bit more about this type of infection from the CDC. You can click there and it'll bring you to the fact sheet.
And just to touch on the co-infection of COVID-19 and mycoplasmic pneumonia, the clinical and radiographic presentations are very similar. So we're seeing the same presentation of fever, shortness of breath, cough, or fatigue. The confirmed number of co-infections is not really known at this time, so future studies are needed to determine the rate of co-infection. It is important to screen for common pathogens that do cause respiratory infections when we are doing COVID testing, just to ensure that we're giving appropriate treatment to patients. And then first-line therapies that are given in the presence of mycoplasmic pneumonia, that's going to be the same things that we previously mentioned. So macrolides, tetracyclines, and fluoroquinolones, and that's going to be given in combination with other treatment options for COVID-19. These are our references, and if anyone has any questions, feel free to see. Thank you.
Thank you.